at the end of each speaker or at the end of the
Oh
whole
yeah,
thing?
yeah. Thank you for bringing that up. So throughout the session, keep an eye on things that come up with chat, and keep an eye on the Q&A, which is live. And sometimes the live questions will come to a particular person, and you can just answer it live. And Grace will give all those instructions at the beginning.
Webinar is going to open.
Thanks, Sasha. Cheryl, I forgot somebody. Oh. Cheryl, you'll go after Carly.
Okay, and Gil, I don't have a camera because I'm a Zoom accident waiting to happen. So
I think it's actually better in your case, Bill.
I think it's much better. So
you know I love you, buddy. How are you, Cheryl? Sasha, are you going to do some fancy music at the beginning?
I think he just opened, and I think he's busy on the OR. So I think
okay.
we are just waiting a couple of minutes. We have 123 people already logged in, and we give them 2 minutes, and then we start, if that's okay.
Oh, I spelled my name wrong.
Okay, so you did.
How do you spell your own name wrong?
Yeah, I was going to ask, did you spell that or did someone else put that in there? Me, you.
No, me, you.
Gil, in this meanwhile, do you want to turn your camera on so I can take our traditional picture? Smile,
I have a number of photos I can substitute for Dr. Gaynor, if you'd like.
Okay, we can do a Photoshop later.
No, he has no camera, so you may as well do it.
Okay.
Okay, I think you're good to go. Hi, everybody. Welcome to Congenital Heart Academy. If you're not following us on social media and not registered to our YouTube channel, please scan the QR code and be with us. It's the easiest way to get to know everything that we're planning for you guys and to review the webinars. So all our more than 200 webinars are there on our YouTube channel, free of charge for you guys to review anytime that you want, including on this webinar that we are starting now. And if you feel that this webinar was helpful for you, you think this knowledge is important for your teammates, please share the link on YouTube to your colleagues. I'm just going to announce a few activities Congenital Heart Academy has prepared for you guys. We are going to have few meetings with our colleagues from Garahan in Argentina. They're going to be in English, so if everybody is interested, you can join. I'm sure it's going to be very interesting. We have our 33rd meeting of the Fetal series. It's going to be very interesting. We are going to continue to talk about fetal cardiac MRI, so join us on September the 18th. And we are proud to support the Fetal and Neonatal Cardiac Symposium that's going to be in the end of this month in Chicago. If you have the chance, please join. And our dear Dr. Norman Silverman is going to give a nice talk correlating the anatomy and the echocardiography in congenital coronary anomalies in October the 2nd. Today we have this very, very nice speakers and a fantastic agenda that Gil and Melissa prepared to us. So please, guys, participate. Type your questions on the Q&A chat box. I'm sure all the speakers are going to be happy to answer and to discuss all of these topics with you guys. Now, Gil, please.
Good morning or good afternoon, or actually good evening, depending on where you're signing in from. We're very excited to present a follow-up over 2.5 years ago now to present some new information in advance of the annual scientific sessions of the Cardiac Neurodevelopmental Outcome Collaborative, which is taking place in St. Louis beginning Wednesday, I believe, in 2 days. And then we're going to hopefully have a follow-up from the leadership of CNOC on all of the new things that were presented at the international meeting. I'm really excited about this particular webinar with a number of people that I've been so proud of working with, and I've read their work. And I think you're all going to learn some really important things that are new in the field of providing excellent neurodevelopmental care and having a philosophy of protecting the brain in children that have cardiac surgery. My close colleague, who's really close, sitting right over there, Melissa Jones, is a nurse practitioner in the cardiac ICU here at Children's National and the director of our cardiac neurodevelopmental critical care program. I'm going to see how good I can do on Zoom. It's only been 4 years since we started to do this. Let's see this. So that should be, is that showing up on
Yeah,
your screen? Yeah.
yeah.
Okay, good. So here's Melissa. Where her focus has been is she's an excellent clinical cardiac nurse practitioner and has really taken an interest in providing the best neurodevelopmental care for our babies. So I'm going to turn this over to you, Melissa.
Okay. 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 Can you guys hear me?
Yes, dear.
Grace?
Yes, we can hear you.
Okay, great. I was using Gil's audio, but I think he just got disconnected. Okay, great. So I am really thrilled to be here to talk to this group about our how we established our NeuroCardiac critical care program here at Children's National. Gil has clearly been a very influential part of this program development and has really helped us to establish our program and really do it in a meaningful way that's been sustainable for almost 7 years now. So to get us started, I have no disclosures. The outline of this I'll talk about how we created and the program and how it's evolved over the course of the past 7 years. I'll review some of the key clinical practice changes and research priorities that we have developed and some of the lessons learned from building this program. So we really started by defining our why. We at Children's had a very strong fetal cardiac program. A lot of the parents were involved in fetal brain research. And we also had a very strong neurodevelopmental follow-up clinic. So there was really a gap in the program at the inpatient setting. So we decided to create a integrated multidisciplinary team that was focused on eliminating secondary brain injury, optimizing brain development, and promoting healthy family bonding in the ICU setting. We really felt like this was an opportunity to impact the long-term outcomes while we have patients and families in our care in the inpatient setting. One of the main tenets of our program is that neurodevelopmental care is not a decision that's made on a day-to-day basis. We don't drive into work and say, it's Wednesday, I'm going to deliver neurodevelopmental care. It's really a series of micro decisions that are embedded in our practice every single day, in every single decision we make. It is the decision to turn on all the lights or turn on some of the lights. It's the decision to have conversations over the patient's bed or outside in the hall, or to provide non-pharmacologic support of pain rather than hitting patients with opioids or benzodiazepines. So all of these micro decisions we really feel impacts the long-term outcome of patients. And so that oops, gives us a lot of ability to impact the longer-term outcomes. So the way I think about how we built our program was we really started with blanket team education. So we did education across our heart center on long-term neurodevelopmental outcomes. We then, from that experience, we built our team. We implemented some clinical practice changes and then worked on some QI and research. So the team education was a really critical part of building this program. We had to start with the why. So why should people care, particularly people who self-select to work in the ICU setting? Why should they care about a mom holding a baby, for instance, or the decision to allow the mom to have the first feed, or getting PT and OT involved for positioning when the patient is critically ill? Why does this matter? So we really provided the education about longer term outcomes of children, and we emphasized the modifiable risk factors in the ICU setting. So what could we do to help improve these outcomes? We included all disciplines. So we had PT, OT, speech therapy, child life, social work, pharmacy, and then of course, physicians and nurses involved in all of these sessions. The sessions encouraged reflection on our own practice. We discussed priorities for our specific program, and this was an opportunity to establish buy-in. And then we committed to standing education sessions in all orientation and ongoing education sessions. This was a table taken from a paper from Dr. Lasanti at CHOP, and it really helped us to frame our discussion of what in the top row here are the risk factors, and here are recommendations for individualized family-centered developmental care. So we used this as a sort of launching pad to discuss our priorities and reflect on our own practice.
It'll be on our
yeah, this is a busy slide, so it'll be on the YouTube channel. You can pause if you're interested. This slide we also used as a way to really emphasize the distinct difference between the developing brain at home and the developing brain in the ICU. We talked about both the overstimulation and the sensory deprivation, an important sensory deprivation that some of the infants get when they're in the ICU setting. So this slide we put up, and we really had a lot of discussion about the differences in the environment and also what we might do in our own practice to get these a little bit closer together. So out of our initial sessions, we developed some priorities. Each education session had a time for reflection. And so all of the notes that we gathered from those initial education sessions helped to inform our initial priorities. And that was helpful both in getting an understanding of where people felt like we had a need within our own program. And it also helped to identify stakeholders and people who might be able to champion some of the practices. So we established neurodevelopmental rounds. We made some environmental changes. We developed a pain and sedation pathway. Parent and caregiver engagement was identified as something that people really wanted to work on, and then neuromonitoring guidelines, so some consistency around that. So team building, we really took a look around and evaluated our own human resources in terms of the therapy team, neurology, psychology, nurses who were interested. physicians who were interested in other hospital-based resources. We were also able to get executive level support for this program. And as I mentioned, the education sessions really helped us to recruit some motivated team members. Early on, emphasis in my mind was to elevate the expertise of some of the therapists, because the therapists are sort of going to see patients and working independently. And I really wanted to bring this team together to elevate their expertise and also have them be a bit more cohesive in their practice. So once we got the team together, we developed a vision, a mission, and some strategic goals. We, as the leaders of this team, met with each individual discipline early to discuss their specific scope, what their passion and expertise are, what their reporting structures were, and any barriers to care delivery in the ICU that they faced. We established team meetings, and then we articulated our priorities, timelines, and some accountability, keeping in mind that this was all work that was done above and beyond everybody's sort of routine job description. So our clinical practice changes, we reviewed the literature, we evaluated the readiness for the unit specific changes. So our team really felt like our sedation practice and our parent engagement was inconsistent. And so we focused a lot on developing a comfort curriculum, which sort of pulled together both parent engagement and pain and sedation management. We identified, I like to call unit champions our influencers. So those are the nurses, mainly the nurses who have a lot of credibility in the unit and really lead by example. So those are the nurses that are going to stop by their neighbor's room who is maybe a newer nurse and say, let me help you get the baby to mom's arms today. You know, those kinds of nurses who will really not just talk about the practice and give lectures about it, but will actually implement it. And those are people that are critical to the success of the program. And then we wanted to prioritize early wins. Oops. So this is our team, and you can imagine over the course of 7 years with a pandemic mixed in the middle that the composition of our team has changed quite a bit, but we've really tried to keep our focus on pulling all the experts together, whoever they are, and engaging them in a cohesive way to deliver this neurodevelopmental care. This is an example of our neurodevelopmental rounds and some of the recommendations that come out of it each week. This practice has also changed. I know a lot of units do neurodevelopmental rounds. We do them every Monday, and we go to every single bedside and write recommendations for every patient and then disseminate that to our full team. This care partnership pyramid is pulled from a paper in 2020, and we really loved this care partnership pyramid. It is something that it provides a visual for how parents can be engaged in the support of their child at any stage of clinical acuity. So a lot of times in the ICU, you know, people would say things like, well, this kid's too sick for developmental care. Well, the truth is that engaging the family and being a parent is developmental care. So if you give the parent the ability to sit up next to the bed and provide positive touch, if they can decorate the room, if they can bring blankets from home, that's fulfilling a parental role, which is developmental care. So we adapted this and put this whiteboard in each room where we have an adaptation of the care partnership pyramid, and then our therapists write recommendations on the whiteboard in each room. And the goal of this was to really improve the care of and really the communication. Sarah Schlotterer is going to talk a little bit more about our neuromonitoring guidelines, but this was also something that our team felt was inconsistent. And so our neurology colleagues really led the way in developing our neuromonitoring guidelines in a database. Quality improvement and research really go hand in hand with clinical practice change. We, as I mentioned, developed a NeuroCardiac or a comfort curriculum, which included non-pharmacologic support, reference table, holding guidelines. And the holding guidelines are both clinical criteria and process for holding patients with different kinds of lines and tubes, and a nurse-driven patient pain and sedation pathway. I won't get into too much detail because Cheryl Caparola is going to talk about our noise study. But briefly, our comfort curriculum, we studied neonates within 5 days of surgery and looked at their cumulative opioid dose before and after implementation of the comfort curriculum. And these are morphine equivalents in 5 days. So it went from 11 to 6 to around 6 in 2 post-implementation phases, which is not clinically significant, but or it's not statistically significant, but maybe shows some trend in the right direction towards reducing opioids with this comfort curriculum. Cheryl's going to talk about our noise study. And then finally, we pulled together a team looking at family support. So we have a CSU family support team, and this was really inspired by a paper that recently came out that was a qualitative study of over 100 parents of children with heart disease. And they worked to develop a model of psychosocial support. And the 3 pillars that came out, which are all listed here, only one of them requires a mental health clinician. So we feel like there's a real opportunity for those of us in the CICU to engage parents in a more integrated care model, and also provide supportive interactions focused on their well-being. This is, in some ways, we might think low-hanging fruit, but I think it's a huge opportunity for us to better support parents, give them strong coping mechanisms as they get through this crisis of stress in their life. Programs across the country and across the world develop differently. I presented how our program was developed, but there certainly are other ways for programs to develop. I think the key is to evaluate the resources that are available in each program and then decide how to launch the program. So some of the lessons learned in our program building were that even the sickest patient can receive developmentally supportive care. So when we really got into it, as I mentioned before, even an ECMO patient with an open chest can receive developmentally supportive care. We can have the parents record their voice and be talking to the patient while they're sedated. We can make sure that the parent is able to provide positive touch at the bedside. We can be judicious about our about sedation and paralytics. We have to be deliberate about our neuroimaging. So there's certainly neurosupportive care that can happen at every level of illness. We worked very hard to elevate the expertise of our team. We invited ourselves to every single education session. So any education that happens, we really want to become embedded in all of that, so that when new staff is learning about epinephrine and milrinone, they're also learning about developmental care. And I think that's how we actually change the culture. We learned that you have to work with what and who you have, and that will change over time. As I mentioned, there's turnover of staff, there's changes in leadership, and we really wanted to stay focused and use the experts that were available to us. Early and small wins build traction. I think this is something we definitely could have done a little bit better. We set out in 2018 to do 3 research studies. And then the pandemic hit, and so it's taken us a longer time to get some of these changes from clinical practice to a manuscript. But we're working on it. So I would suggest, if I had to do it again, I would have picked one important project and studied that and focused on that rather than spreading ourselves so thin. Taking care of parents is developmental care, that reestablishing the parental role, making sure that parents are both part of the care team decision-making, but also part of the bedside care whenever possible is developmental care. And then finally, culture change takes time and patience and some persistence. So it's not necessarily easy or, you know, a smooth road, but I think some persistence helped us to keep going through these years. This is our amazing team, and I really am so grateful to be part of it. And I'm happy to take any questions. Thanks.
Thank you, Melissa. Before you do that, I'll use your audio.
Okay.
Thanks, Melissa. I'll introduce Sarah as well. And again, just to remind everybody, a couple of things. This entire webinar will be on our YouTube channel, along with the Congenital Heart Academy's other 200 webinars, which started in the pandemic. And for those busy slides, or you just want to take a look at that, take a look at them again. You could look at them on the YouTube channel. Please remember to give credit to the presenters if you do borrow that material for your own presentations. Next, we have my colleague, Dr. Sarah Schlatter, who's a pediatric neurologist and is the director of our critical care neurology program here. Hope I got that right, Sarah. And Sarah's going to talk about the critical role of an integrated pediatric neurologist within the cardiac intensive care unit. Sarah.
All right, thank you, Gil. And I'm actually the medical director of NeuroCardiac critical care. So we have another physician who's our neurocritical care director. But I'm really excited to be a part of this panel today. And I guess I can just dive right into talking about the role of the neurologist in the cardiac ICU. Can everybody see my slides? I guess I should have put on this disclosure slide that I am, as Gail said, a neurologist and not a cardiologist. I don't have any disclosures relating to this talk, but I do have research that's been funded by the Van Meter Foundation and the William Willard Charitable Foundation. So we're all here because our patients have high risk for neurodevelopmental delays and disabilities. And I think that's the whole purpose of everyone being on this panel, so I won't belabor this point. But what I found in speaking with some of my colleagues is that despite the fact that we know that our patients often have significant neurologic disabilities, neurologic issues, in many cases, the neurologist is not someone that you see as frequently in the cardiac ICU. And I hope that in the next 10 to 15 minutes, I can convince you that neurology is an integral part of any team who wants to care for children with congenital heart disease. And I've been very fortunate to work in a center where I've been welcomed into the unit and where the entire neurology team has really been welcome in the unit for many years, even preceding my tenure here. So how can we be part of the team? Why should we be part of the team? I'm going to start with some fairly sort of the traditional ideas about why neurology should be involved in the cardiac ICU. And those common neurologic issues are brain injury and seizures. And so we know that our patients with critical congenital heart disease have high rates of brain injury, particularly white matter injuries and strokes. They have brain injury preoperatively and postoperatively, although our rates of brain injury are declining, as was shown in a nice paper by Pivandi et al. That came out recently. And the rates of injury are pretty high in our patient population. I've quoted some of the rates from the literature here. But we know that certain types of brain injury impact long-term outcomes. We know that severe white matter injury is associated with motor outcomes in infancy. We know that strokes affecting the cortical white matter are affected with are impacting motor outcomes. And we know that hypoxic ischemic brain injury is also associated with long-term diagnosis of cerebral palsy. And white matter injuries have also been variably associated with other things like long-term cognitive outcomes, et cetera. And so it's important that we're identifying brain injury where we can, and talking to families and making a plan for getting our patients into the appropriate therapies to optimize their long-term outcomes. I think seizures are one of the most common things that pediatric neurologists deal with, one of the most common diagnoses that we treat. And in our population in the cardiac ICU, seizures are incredibly common. In most more recent studies, we know that about 10 to 11% of babies, of neonates who have a bypass surgery, will have a seizure in the immediate post-op period. The critical window is about 24 to 48 hours post-operatively. And what's important to understand about these seizures is that the majority of them are electrographic only, meaning we don't see anything outwardly or clinically in the infant that tells us that this baby is having a seizure. And so it's really important that we have EEG monitoring for these children and that we have someone that can interpret those EEG. I think the other important thing to keep in mind is that among the children who have postoperative seizures, who have those acute symptomatic seizures, status epilepticus is a common finding and can be up to 62%, depending on which study you read. And I've been asked by some of my colleagues in the ICU why we should care about seizures if they don't have a clinical correlate. Why should we care about seizures only on an EEG? And it's because seizures can correlate with outcomes. Children who have seizures in the cardiac ICU have higher mortality rates. Seizures are highly associated with brain injury, and in fact may be a first signal to us as a team that this child has brain injury and should trigger imaging. Seizures are associated with longer ICU and hospital stays, and with an increased lifetime risk of epilepsy. About 3 to 5% of infants who have a postoperative seizure will go on to develop epilepsy in their lifetime. And while the association between seizures and long-term developmental outcomes has been mixed in the literature, there has been some good evidence that seizures have been correlated with worse executive functioning and social interactions at age 4 and with lower IQs over time. And so it's important for us to be identifying these seizures in our neonates who have bypass surgery. But what's been a real challenge, I think, in the cardiac ICU world is that we don't have clear guidelines for much of what we do. There are wide variations in practice in North America and in Europe. We really have no consensus guidelines for imaging. Who gets what type of imaging and when is still up for debate. And there have been clear guidelines for EEG monitoring by the American Clinical Neurophysiology Society since 2011, namely that they recommend that neonates that are status post-bypass receive at least 24 hours of continuous video EEG monitoring post-operatively. But these guidelines aren't well known and aren't necessarily in journals that are frequently read by our colleagues in the cardiac ICU. And so I think in addition to being called in to treat acute neurologic disorders, one place that you can leverage your neurologists and have your neurologists involved in the care of your patients is having us assist with determining what the best practices are. How do we do neuromonitoring in your individual center? And that may look different for different centers. Not everybody has the privilege of having readily available continuous video EEG monitoring for every baby that's status post bypass. But perhaps you have amplitude integrated EEG. Perhaps you can develop guidelines for imaging that fit with the resources that are available at your center. And I think this is an important and sometimes overlooked role that neurologists can play in the cardiac ICU. And so, as Melissa said, I'll share just a very 10-foot, 50-foot view of what our neuromonitoring guidelines are here at Children's National, where I work. And we do both a pre and post-operative or pre-discharged MRI for all of our neonates that are status post-bypass. And we do 48 hours of continuous video EEG monitoring. And these guidelines have been in place for many years and were actually implemented by my predecessor, Dr. Jessica Carpenter, and modified by Dana Hara, who preceded me in my role at Children's National in the cardiac ICU. And so we've had a long history of pretty intensive neuromonitoring, and Dr. Licht is going to talk a little bit more about NEARS and beyond NEARS, so I won't go into that. But what we've done more recently, and what I think is another important factor in thinking about the role of neurology in the cardiac ICU, is how do we communicate across teams? How do we educate each other when sometimes the goals for caring for our individual systems can be at odds with each other? And what we've implemented in our center that I think has been quite successful has been a dedicated time each week where the neurocritical care team comes together with the cardiac critical care team. And we have a dedicated time where we go through the cases that are active in the unit that have neurologic issues. The neurologists learn from the cardiovascular ICU team about the cardiac physiology, medical issues that these children are having that may impact their neurologic status. And the neurologists talk about the imaging, EEG, and we come together to form a shared mental model of our patient so that everyone on the team is thinking about how we treat the whole patient and optimize not only the medical, but also the long-term neurologic and developmental outcomes for our patient. We call this the neuro huddle, and we've been doing it for about 1.5 years. And this is the other key place where I think neurology and cardiovascular ICU collaboration can come together to help us improve outcomes, is by having buy-in from both sides. And I've been really privileged to work where I do and have wonderful colleagues in the cardiac ICU who show up to the neuro huddle. The last thing that I think, the last point that I want to make quickly is that, there are so many things that contribute to the long-term developmental outcomes of our patients, as Melissa pointed out in her talk. And I would be remiss to focus only on brain injury or seizures or on specific acute neurologic issues. And these issues span across the prenatal period through the perioperative period and into the long-term lives of our patients. And so the last place that I think that neurology can really be leveraged in the care of our patients in the cardiac ICU and beyond is to think about neurologists as another service, another team member that can provide continuity of care for our patients across the lifespan. And at our center, we have started actually talking to families prenatally about the brain, talking about how we're going to monitor the brain and protect the brain, and how we're going to follow children throughout the lifetime. And parents have appreciated this. Parents are stressed about their baby's developmental outcomes. They go on the internet, they read about these things. And so addressing some of that before the parents and the patients are in the high stress environment of the CICU, I think has been something novel and something that's been very helpful that we've, again, implemented in the last 2 years or so. And then having neurology as part of the long-term care team, focusing on neurodevelopmental outcomes, focusing on neurodevelopmental surveillance, and participating in individualized developmental care in the unit and beyond. So this is really the model that we're aspiring to in terms of our neurologic care of patients at Children's National. Again, we're never perfect on all of these aspects. Certainly, every patient is a new challenge, but this is the model that we're aspiring to, which is to really provide care across the spectrum from the prenatal period through the postnatal and perioperative period, and to follow our patients up in the long term. And in fact, having this communication in neuro huddle in the cardiac ICU has also allowed us to provide updates to the ICU providers about the patients that have been discharged that we're now seeing as outpatients and how they're doing. And that's been a really fun, community building experience to be able to do that with our colleagues in the unit. So I hope in this very brief talk, I'm trying to keep it short in the interest of our other speakers. I hope that I've convinced you that neurology is a critical piece of the puzzle when it comes to multidisciplinary care of our patients with congenital heart disease, and that neurology can be involved in, of course, the typical neurology things that we think about, which is diagnosing and treating acute neurologic disorders, but that we should also be engaged in developing and implementing neuromonitoring strategies that are appropriate for each individual center's patient population and their available resources. That neurology and the cardiac ICU team can form coalitions where we communicate, we educate each other, and we form shared mental models of our patients that improve our care and our own sort of working satisfaction with our jobs. And that neurology can also be involved in continuity of care across the lifespan for our patients. And all of these pieces, I think, are important, and I've been very privileged to be in a center where neurology is welcomed, as I said, and is involved in all of these aspects of care of our patients with congenital heart disease. And I hope I've encouraged you to reach out to your neurologists if you haven't done so already. So with that, I just want to thank so many people who have supported and been a part of my own development as a neurologist. And thank you all for taking part and for listening to this.
Thank you so much, Sarah. I really always love your presentations, and that was a really nice overview of the value of a neurologist in the ICU setting. And I'm so lucky I get to work with you. I also am really excited to introduce Dr. Gail Wernovsky, who is so proud to be the director of nothing, but is a mentor to many, so including me. So I am going to turn this over to Gil.
Thank you.
And he's going to talk about.
I don't know. I'm gonna have a controversial. I'll have a controversial topic. Before I start, I just want to remind both the audience and the panelists that there are the best way to send any questions in is through the Q&A at the bottom of your Zoom screen. You'll notice if you click that there have been 4 questions. 2 have been answered, so you can go in the Answered tab. There are a couple talks that either Dan or Sarah, if one of you could take a look at, and when people are asking about neuroimaging and EEG, we have the opportunity to have this back and forth dialogue during the webinar, and Zoom certainly affords our ability to do that. I'm going to get my purposely controversial talk up here. Just close this. And I'm glad that Dr. Bill Gain and Dr. Eve Dudichem are on this, because I've just decided to go a little bit over the top with this particular talk. Let me see if I can move this forward here. I have no disclosures, and these pictures are with parental permission. We all like, when we come into the cardiac ICU, to think that we are dealing with fact, with evidence-based medicine to treat our patients, and that we're operating from the truth that's been handed down from the generations before us. But in reality, what ends up happening for all of us is that we are based in clinical practice based on the way, quote, we do it at our institution. There's a lot of different ways that work. And certainly I'm not implying that any of these are wrong, but it's important to recognize that it's important for us always to question what we are doing as a team and what we are doing as a field for the best outcomes for our patients. And I want to start with this paper, which was published 35 years ago in JTCVS by my mentors and my colleagues at Children's Hospital in Boston, where the idea of primary repair and primary surgery in the neonate was put forward in the mid-'80s. Now, we have to remember what was available to us in the mid-'80s as options, as well as what was available to us in the intensive care unit at that time. The paper has been cited 209 times, and I'm not going to go through all of these papers, but basically it's been taken as a truth that critical congenital heart disease should be taken care of early in the neonatal period. As you can see, as I said, I'm not going to go through all of these papers, but there's not really been anything since then that talks about not doing an operation for duct-dependent or critical heart disease. That's me on the right of, as I said, 35 years ago. To my right was Dr. Castaneda, Dr. Burke Jonas, who worked here and recently retired, and Dr. John Meyer, and really put forward this idea along with our ICU and with cardiac anesthesia that this was the way to go. But how many things from 1989 would you say are still true 35 years later? That's a tough one. The things that I was sure of and I was taught and then I taught in the cardiac ICU included a good operation fixes everything. Repair early rather than palliate, as we've been talking about. The majority of babies were normal except for their heart. Seizures were not a bad prognostic sign. In fact, Dr. Norwood famously called them baby twitches. Our practice at the time was prolonged neuromuscular blockade and high-dose narcotic anesthesia were also necessary post-operatively. We typically had patients at that time on 10 mics per kilo per hour of fentanyl and neuromuscular blockade for 2 or 3 days following surgery. It was recognized that some of the survivors had developmental delay. Cardiac arrests happened at night and almost always were blamed on the nurses, and that the team did something wrong, which of course is incorrect, and that it was probably a good idea to wait a week or so to operate due to so-called twitchy pulmonary vascular resistance. These were truth. This was the way we practice, and we were sure that we were right, just like we're sure we're right in the things we do right now. So I'm going to talk about 2 of these things, which is repair early, and some survivors had developmental delay. What we do know now, summarizing amazing work, a lot pioneered by David Bellinger and Jane Newberger in Boston. And this is summarized in Brad Marino's guidelines that were published in 2012, but were just updated in 2024. Half of our survivors of critical congenital heart disease have ADHD, 40% with deficits of social cognition and executive function, about 35%, and I'm curious to see what Carly says about this, with oral motor problems, as well as gross motor and fine motor dysfunction, 30% with apraxia of speech, mood disorders, cognitive disability, a 10 times increased incidence of autism, and at least 30% of families have PTSD and other mental health challenges. In every single reported study, every single one, this is longer post-operative length of stay, maternal mental health, if they've had cardiac arrest or ECMO, if they've had renal failure, and if they were a baby when they were operated on. These are consistent risk factors for the neurologic delays that we just talked about. So I'm going to say, let's start from scratch. We'll say we're going to do Control-Alt-Delete today. What's the best way to take care of complex congenital heart disease? I stole this slide from Melissa because I love it so much, because and I think a lot of this changed when I became a grandparent and looking at babies and parents sitting in the ICU that were expecting this and got this. And so from a family perspective, as well as from a baby perspective, this is very, very abnormal. And our goal is to maximize neurodevelopmental care, neurogenesis, healthy family bonding, and minimize the effects of secondary brain injury that can occur in the cardiac ICU, such as from things we'll hear later today, noise, opioids, et cetera. This isn't normal if you're a parent, and it isn't normal for the brain if you're a baby. We sort of walk by this stuff every day in the ICU. We're used to it. And I think we have to remind ourselves how abnormal this is every time we walk by a bed space. So I've talked about the current developmental outlines. I'm going to talk briefly about the developmental biology of the neonate's heart, kidney, gut, and brain, as well as the neonatal maternal dyad. And then I want to leave you with some additional definitions of outcome. If we look at what the baby with a structurally normal heart goes through, we know that in the first roughly month or two is when the period of maximum hyperplasia and hypertrophy occur. And it's thought that creating new cells and angiogenesis are really limited to that first week or so of life, as you can see here. So we take this baby whose heart is stiff, whose heart is adapting, and we give cardioplegia, we give cardiac arrest, we see high lactates and low cardiac output in the, this is Anthony Rossi's data on HLHS. We've seen all sorts of papers now that show this slump that occurs in the middle of the night. And then there's this upper right shows that the NIRS is going down, and then there's a cardiac arrest and we end up on ECMO. So it's not just that the heart is abnormal, the low output state contributes to abnormal cerebral oxygen delivery. What about the kidneys? Well, we do know that the kidneys are immature at birth, and in fact, considerably immature. This is data in dogs, where you get about a tripling of the GFR and the filtration and the plasma flow in the first 2 months of life. We see exactly the same thing in babies. This is the glomerular filtration rate in infants, which tends to double in the first 2 months of life. This is with structurally normal hearts. Now, what if you superimpose cardiopulmonary bypass on that immature kidney? This is data from the Primacorp study. These are neonates on your left with biventricular repair, so not our single ventricle patients, who postoperatively have a measured GFR by urine collection between 24 and 37. Whereas the babies that were operated on later had essentially normal glomerular filtration rates and could remove fluid. So all of the swelling that occurs cardiopulmonary bypass and the heart dysfunction is now superimposed on kidneys that do not clear fluid as well as they will in a month. I've been learning, it's interesting to learn new things, been learning a lot about the gut in the baby, and I'm not going to go through all of the details, but it's very complicated in terms of whether they get antibiotics or not, whether they get breast milk and get passive immunity or don't get breast milk, how much contact they have, how much eye contact they have with the mother. But we know that the role of the gut and oral feeding is for both digestion and absorption, provides immune competence, provides the initial intestinal microbiome. If you feed preoperatively, you're more likely to feed postoperatively, and maternal-infant bonding is hard to measure, at least sort of what I've been able to look at. But we do know that human milk is associated with improved neurodevelopment as well as passive immunity. So what do we do when a baby comes in? We give them antibiotics and we make them NPO. So probably the worst things that we could do for the development of the normal microbiome and digestion and absorption. There's an entire meeting for 3 days about the brain. So I'm not going to be able to go through this right now. I'm going to use the simplistic cardiology method. The brain grows a lot in the first 3 months, and that's a surrogate for brain growth. And I'm going to just leave it at that because it's very complicated. And I don't want to spend too much time on that, but I do want to talk about what happens when you have congenital heart disease, complex congenital heart disease in the transitional circulation. And I think you'll hear a little bit more about that as we go forward. A lot of this work has been done by Dr. Licht and Dr. Lynch at CHOP and others. You could see in the upper left that the cerebral oxygen saturation falls continuously from birth in the first week or so of life. We know that flow to the superior caval vein goes down as pulmonary blood flow goes up, and that's because of the ductus, and that's whether you have 1 or 2 ventricles. This is work by the group in Stollery, which compared 30 fetuses with hypoplastic left heart syndrome to 18 with a structurally normal heart. The patients with HLHS are in red. And you could see, as you know, the combined cardiac output of that single RV has to match the cardiac output of 2 ventricles because it provides both systemic and pulmonary blood flow. It does that by increasing stroke volume and increasing heart rate. But importantly, these babies that look good from the outside are having all sorts of difficulties on the inside. The acute volume load on a single RV, for example, is not matched with mass increase, at least for a week or so. So you've got this increased RV volume work, but no increase in mass, dilation, potential tricuspid regurgitation, and the flow is abnormal. Of this combined cardiac output is a multi-distribution circulation. So systemic blood flow is about half normal, pulmonary blood flow is about twice normal, and importantly, SVC return from the brain as well as gut flow are all down. So before the babies make lactate, there's a period of pre-metabolic acidosis that's described here. So I've sort of changed when I see these babies looking good from the outside with, quote, high saturations and whatnot, and think this is a tenuous situation, especially for single ventricle. I don't allow anybody in our unit to say this anymore because there is no baby stable on prostaglandin. We know that I showed you a little bit of this data. Dan may go over this a little bit, but cerebral blood flow falls daily, and cerebral oxygen delivery falls daily, and that's from a steal into the low resistance pulmonary circulation through the duct. It affects the brain, it affects the kidney, it affects the coronaries, and it affects the gut. So a standard Norwood, for example, in the first week of life superimposes that myocardial ischemia, hypothermia, et cetera, when we've got immature kidneys, an adapting myocardium, a rapidly developing brain, and then they come out with a physiology that's still inefficient. So here's where I'm going to leave you with some controversial ideas, and that is we have to sort of be ready to not just tweak the way we do neonatal surgery and make it better, but reconsider now that there are more tools in the interventional cath toolbox to delay neonatal surgery to a lower risk period. Now, we know that it's been said before, 28% of the neurodevelopmental variation in scores is related to these three challenges: maternal worry, maternal mental health, and visual perception abnormalities in the child. And that's from great work by George McCusker and his colleagues in Ireland. I'm sorry that I love the fact that we have family presence in our ICU, but that up at the upper left-hand corner is not normal. It's better than the options of not being there, but that's not normal. I'm glad we're making some progress in that regard. The families have to see all of this. Dads are different. I'll just leave it there. And depending on your unit, the parents are exposed to all sorts of vicarious trauma. This is an incredibly difficult time for them. And as I mentioned before, this is an opportunity for improvement. If 25% of this is due to the parental mental health, let's get on top of that now. All of these risk factors, and this is a figure from the paper Dan and I wrote a number of years back, every one of these preoperative risk factors, when we do bypass, postoperative risk factors, and parental anxiety is modifiable by cath interventions. When a baby's sick, the mother is sicker. I had trouble giving my kids amoxicillin 3 times a day. I don't know. We do know that having a gastrostomy tube is related to a lot of maternal dissatisfaction and taking away the maternal role. Having to from the families, they send them to us. But again, it's a reminder every day their baby is sick. This is important work from the SVR trial, where only about a third of the patients went home with full oral feeds. I don't know if I could do that personally every day, put an NG tube down my baby if it came out, or feed by gastrostomy tubes. And then the medication burden we send these babies home on. The typical range is 2 to 9 medicines multiple times per day.
Dr. Valentino to the OR, please.
I can tell you when the families come back into the ICU and just hear this, it's incredibly traumatic when they come back, and we're so happy to see them. Oh, the baby looks so good. And remember what they're going through at that time. So I think we have to rethink individual babies and do the right procedure for the right patient at the right time. Preserve their myocytes and their pulmonary arteries, but also their brain cells, their renal cells. Preserve oral feeding. Very, very important in preserving our patients' and our families' quality of life. I'm going to challenge this notion from 35 years ago. I'm glad we can do it and we should do it when indicated, but we should be rethinking what's the right way to approach these babies so that we can get closer to this type of brain development in the cardiac ICU. So we know right now all of these things are happening in the immediate transitional circulation, as well as postpartum recovery and maternal bonding. And if nothing changes, nothing changes. And I can feel through the Zoom the resistance to the change to stop doing neonatal surgery if we don't need to. This is our current model. Our risk, as we've shown, is with the transitional circulation followed pretty quickly by surgery on cardiopulmonary bypass, and we don't do those things. And we end up with this many times, not all the time, of course. So we also end up with cardiac arrests and renal failure and seizures and bad feeding and medication burden and months in the hospital. So if we put that together over there on the right, and we also talk about what I showed at the beginning, this is our current practice. This is what we see and what we see in follow-up for neonatal heart surgery. That's the data. One, they want to disagree with it, but that's the data. And it's become expected, but in my view, it should not be accepted. There are other ways that we can approach these particular problems. How do we do that? Well, in my mind, the first thing to do is to mimic the fetal circulation in the cath lab. Limit pulmonary blood flow, provide unobstructed systemic blood flow, either with a stent or with prostaglandin. Be sure the atrial septum is open. I'll say it again, limit pulmonary blood flow. That is a problem in the first few days of life. And that can be done with all sorts of interventions. That's a flow restrictor on the right. I wanted to show you this Medtronic device, which is actually a flow occluder, but this is one of our surgeons, Dr. Manal Desai, and what he's doing is creating a flow restrictor that my colleague Josh Cantor put in one of our patients. Very detailed cutting through the vortex membrane, as you can see there, and then ending up with a hole right there. And he made a number of holes in this device to restrict pulmonary blood flow. The idea here is to go to the cath lab, restrict pulmonary blood flow, stay on prostaglandin, extubate the baby, and put the baby in mom's arms, and limit that period of time of hemodynamic instability for that. And then move that period of risk. Sorry, let me get back to here. Move that period of risk out there. Right procedure for the right time. I'm not sure why that got back in there again. I'd like people to consider 3 additional important outcomes to measure. Going home on tube feeding, full or partial, being on tube feeding at a year, the number of medications that the baby needs to take on the day of discharge and at 1 year, and the days out of the hospital in the first year of life. It's not just the 4-week or 5-week neonatal stay. It's the admission for bronchiolitis. It's the admission for the cath. It's the admission for all other things that completely turn the family upside down when they have to find coverage for daycare or whatever else it might be. And then I'll close with Einstein. We cannot solve our problems with the same thinking we used to create them. The choice we make now in the neonate makes a difference when they get to school. So thank you very much for your attention. And I hope that was as controversial as possible. Our next speaker, and again, put some questions in there. And our next speaker is from Nemours, right up the road from us in Wilmington. Carleen Egren is a speech and language pathologist and an expert in the area of feeding babies and the difficulties with feeding babies in congenital heart. I think I'm her biggest fan. I'm going to turn the screen over to you now, Carly. Thanks.
Thank you. What a tough act to follow. Thank you. Okay. It's an honor to speak with you today. We just heard some incredible endeavors to protect the infant's brain, which is the first line in defense in protecting infant feeding. So kudos to all of you leading this important work. And why does it matter? Nothing gets people's emotions more stirred than feeding, because providing nourishment to a fellow human is associated with one of the most powerful emotions we have, and that is love. And when you disrupt something of this significance, this leads to stress and trauma. Feeding rapidly develops in infancy, and yes, there is a sensitive window to acquire foundational feeding abilities. Unfortunately, this sensitive period of development is juxtaposed against imperative life-saving cardiac interventions. In the first moments following birth, an infant communicates that he is reliant on his parents to thrive, and the parent responds. This creates an interdependence between them, also known as bonding. And feeding is a reflex in the first few months of life, which is why the majority of babies in your ICU have strong sucks on the pacifier. You know, I often hear, well, they're going to do great on their feeding evaluation because they have such a strong suck on the pacifier. But we know that that's not a marker of feeding success, because that is a reflex. And then with exposure, the brain begins to map the challenging suck, swallow, breathe sequence, which is a novel postnatal skill. And you can see that there are multiple disruptions for medical interventions during this very important feeding milestone. And then at 3 months of age, the brain assumes that through survival, the infant has learned to feed, and the infant feeding reflexes disappear. And it's a good thing that they disappear so early in life. If they didn't, if someone stroked your cheek, you would start to root and suck. And so that's a good thing they go away. But at this juncture of development, infants can no longer rely on their reflexes to feed. And feeding is now a motor skill that has been imprinted on the brain from exposure, and it's a learned behavior. So then you're thinking, okay, well, we have to maximize on this reflexive stage, right? Okay, well, you're not wrong. It's a start. Let's take for a moment and compare premature feeding science to cardiac feeding science. Many of you in attendance no doubt dabble in both. Regarding the premature infant, you can see that we have the gestational ages in blue starting at 30 weeks. And the above circle in red means we're not feeding the infant at this point in time. The circle in yellow means that we're starting to expose the infant to feeding around 32 weeks. And the circle in green means that we are starting to liberate oral feeding for a premature infant. Now let's take a look at the infant with CHD. Don't forget that an infant with CHD is usually born full term. And this chart assumes that the baby was exposed to some feeding following birth, and then they get benched for cardiac feeding interventions. And then we begin to expose them again to feeding. However, they're sedated and in recovery from a major procedure. And right here is when we're in the reflexive stage of feeding. And then what happens around 3 months of age is that the infant feeding reflexes integrate, and feeding is a motor and behavioral task, meaning that that infant will decide to eat on volition and will draw from the oral motor abilities and behavioral experiences that they have gained. So this is where us feeding therapists are suspicious that we're creating oral aversions. It is a careful balance between exposing the infant to feeding, but also making those experiences positive. Unfortunately, hospital discharges are happening right around that important juncture, and we're starting to push infants to orally feed right around the time period where those infant reflexes are peeling away and that they are engaging in a behavioral response to feeding. And so we are thinking as feeding therapists, we really do need to direct our attention, not just to preoperative feeding, which we know is important, but during this critical time when a baby is starting to develop behaviors to engage in feeding and having the negative feeding experiences that come from, oh my goodness, can we just discharge this baby without a feeding tube and kind of force the baby to eat? Don't forget that infants with CHD are in a state of recovery and development at the same time. We all need to ask ourselves, what can I do at this juncture of this infant's surgical, physiologic, and developmental course to protect feeding? Of course, we just heard about brain protection, gut protection, which is super important, engaging in oral motor activity, intubation practices, sedation practices, and the use of human milk all have been known to protect feeding. But you've got the baby out of the OR now, you've got them extubated, they're weaning from sedation, and you are a cardiac intensivist now standing at rounds and asking to create a feeding plan for that baby for the day. And you're asking yourself, okay, so I've done all this protective strategy, but what exactly makes the provision of feeding and nutrition developmentally supportive? Okay, well, I'm going to give you the answer. You're going to ask yourself these 4 questions when you're making a feeding plan. Feeding is developmentally supportive when the infant has a voice in the provision of their own care. And this is done through infant cued feeding. This means that the infant has a consensual relationship with being fed. 2, the feeding plan matches the developmental abilities of the infants. This is not measured by looking at metrics such as percentage of PO or mode of nutrition. I know those things are easy to look at in the EMR. They're nice and easy to put in there. And they're easy to look at in data registries because we can pull from them. But developmental feeding evaluations need to be done so that the feeding matches the developmental abilities of the infant. And that the care team is responding, altering, or discontinuing their course based on what that infant is communicating about their feeding, and that the family is the primary caregiver in feeding. Developmental feeding is a matter of respect to the tiny human at their most vulnerable moment. This paper really outlines some more specifics. This is the developmental care pathway for hospitalized infants coming out of the Cardiac Newborn Neuroprotective Network. Take a look at that for more resources. Now let's talk about another exciting quality improvement initiative launching out of the Cardiac Newborn Neuroprotective Network, and that's the First Oral Feed Initiative. In most circumstances, when an infant is born, the baby is delivered and placed almost immediately skin to skin. Both the infant and the mother are united in the physical world, and instinctually, their bodies come together to feed. But we know our babies are different, and those of us who work in the busy surgical ICUs, we know how this happens. The baby's stabilized, the tests are complete, the surgical palliations are performed, and now an order is placed to feed. So you put in an order to feed, and the earliest feeding experiences, which are important for bonding, are casually performed as a task by the nurse without the parent being notified nor present. They have been bedside for weeks, but were not even considered to be notified when their baby's fed for the first time. We just had an experience at our local hospital where a mom was down at the cafeteria getting her coffee and her baby was fed in those moments that she left for the first time. So we are displacing the role of the parent as the primary caregiver in feeding by feeding babies without their involvement. And we take this from her, and she'll never get that first oral feed back. So we have some exciting news in the cardiac QI world. The Cardiac Newborn Neuroprotective Network instituted a multi-institution QI project. As a matter of fact, 15 different hospitals are enrolled to evaluate this very problem. And our baseline data is revealing that the majority of infants are fed for the first time without their parents present. This project is gaining momentum, and stay tuned for further report out. And finally, breastfeeding experience is developmental care, despite the perceived barriers. I'm not going to argue with you that there are barriers to breastfeeding, but parents desire to experience what breastfeeding might feel like. And I'm not talking about exclusive breastfeeding. That's a big leap, but it's not all or nothing. Can we allow our mothers to have a safe and controlled breastfeeding experience without jumping to the fact that we're talking about exclusive breastfeeding? Can we do it at once? Can we do it 1 time, 2 times? Is that reasonable? Well, let's look at this video here of this mother doing a breastfeeding experience. This is an infant with stage 1 cardiac physiology, intracardiac lines, vocal fold paresis, and we made safe modifications to provide this mother with breastfeeding experience. You can see the baby's not latching, but this experience meant everything to this mother. There she looks at me and says, "Thank you." And this is developmental care. Developmental care with feedings are the small things that have the greatest impact, not whether or not a baby is fully feeding by mouth or not. Thank you for letting me spend my morning with you, and I look forward to hearing from you guys in the chat.
Ron.
Carly, Carly, thank you as always for a very engaging talk about feeding neonates. We really appreciate your expertise. I am going to introduce Cheryl Caparola. She is a cardiac intensivist at Colorado Children's, and she and I worked together closely on our NeuroCardiac critical care program when she was here at Children's National. She's going to talk with us today about noise in the ICU.
What? I think you're muted, Cheryl.
There we go. I lost the mute button when I shared, so now I'm back. All right. So as Melissa said, I'm going to talk about noise and its consequences in the CICU today. To do that, I will first talk about what noise is, how we measure it, and then we'll talk about some consequences and then some potential benefits or research to determine that. So sound is just something you hear. It's the vibrations in the air that allow us to hear something. But noise is an unpleasant or undesired sound. It's the horn beeping down the street, the loud music your children might be playing that you don't want to hear, all those unpleasant, undesired sounds. When we look at volume, we measure that in decibels. This is a logarithmic scale, and which means an increase in 10 decibels can represent a doubling in sound. So you see here, I have listed just some examples of different things and what the decibels are. A refrigerator, the hum you hear in your refrigerator is around 40 decibels, where rain outside will be about 50. A dishwasher is about 60. Vacuuming is 70. Loud traffic is around 80, and a lawnmower outside is around 90. It's around 90 to 100 that can cause some hearing loss, but around 60 to 70, think about that vacuum at home, that can be annoying to our ears. Excessive noise is associated or has been shown to be associated with patient discomfort, abnormal sleep, which then can contribute to delirium, can lead to hemodynamic instability, can disrupt normal growth and development in infants through physiologic responses, and can contribute to the post-intensive care syndrome. Think about all those alarms that we hear. It's been about 25 years or so since noise identified in the OR, PACU, and ICU areas of the hospital are all above recommended decibel levels. In fact, the World Health Organization, the EPA, and the AAP have all made recommendations for decibel levels within a hospital or a working environment. So the World Health Organization says that patient rooms should not exceed about 35 decibels. That's quieter than the refrigerator hum. And maximum should be as loud as the refrigerator hum at 40 decibels. The EPA says that indoor sound levels should not exceed 45 decibels. And the American Academy of Pediatrics also says that for infants and neonates, the hospital should not be above 45 decibels. And as you can see, it's right around that refrigerator or raindrops, which I don't know about you, but for me, that's pretty quiet. In fact, most ICUs consistently record sound levels that exceed these recommendations in numerous studies. In 2017, Dr. Garcia Guerra and his colleagues measured noise levels in 39 patients in their cardiac ICU in Edmonton, and they found, as I just said, sound levels were consistently above the recommended values. In fact, they were around 60 decibels. They found no difference between daytime and nighttime. We would hope that nighttime would be lower, but they did not find that in their cardiac unit, and that there were no difference between open areas and patient rooms. Interestingly, but not surprisingly, there was a significant association between average and peak noise levels and the number of sedation PRNs given. Therefore, the louder it was, the more sedation a patient received. With that, in DC, we decided we wanted to evaluate the sound in our CICU and look not only at its association with sedation, but also delirium and hemodynamics. Therefore, we performed a prospective observational cohort study. We put these sound decibel meters, as you can see in this picture, in our 26-bed unit in all the rooms. We have 22 private rooms, 4 semi-private rooms. Semi-private room is 2 beds shared in one large room with a curtain in between them. We put these decibel meters on the boom next to the monitor, thinking that that would be the most consistent place that they would be close to the patient to get as close to what the patient is hearing as we can. We did this over 5 weeks. These decibel meters recorded the sound or decibel level every 5 minutes. Over that 5 weeks, we had 68 patients who were enrolled. We had an average daily census of almost 18 at that time, and we recorded 166,228 individual decibel meter recordings. With that, we found very similar to other studies that sound levels were consistently above that 45 decibel mark at all times. And it was significantly higher during the daytimes than nighttime hours by about 1 decibel. As you can see here on these graphs, on the left is the average daytime sound levels, and on the right are the maximum noise levels. The average daytime level was 50.6 decibels with a maximum of about 77 decibels. The average nighttime sound level was 49.5 decibels and the maximum 69.6. I guess I could explain these graphs a little bit more. The blue in both of them are the daytime shifts, so 7 a.m. to 7 p.m. and the red is a nighttime shift, 7 a.m. to 7 p.m. And then again, with the average being on the left and the maximum noise levels being on the right. An increase in the maximum sound levels were predictive of an increase in heart rate, as well as the systolic, diastolic, and mean blood pressure. So on the left here, we have the mean blood pressures on the x-axis, and on the y-axis, we have the average noise. And as you can see, as the average noise increased, the mean blood pressure also increased. And on the right, we have the heart rate showing the same. An increase in average and maximum sound levels during the nighttime hours, particularly. There was a trend during the daytime, but significant only for nighttime, increased the probability of sedation administration in the following hour. This was consistent with Dr. Garcia-Guerra's study that I mentioned previously. We did not find any association between sound levels and delirium, although we also think that is because we weren't monitoring the compliance with delirium screening, and so we may not have had that many screens of delirium to fully capture that. As far as we know, this is the first study linking sound and hemodynamics, and demonstrates that increased sound can lead to increase in stress in a very vulnerable population in the CICU. Overall, we think this suggests that if we can decrease noise or sound levels, there's a potential to decrease sedation needs and decrease potential stress in our patient and ultimately improve neurodevelopmental outcomes. As I said, I'll try and talk about, what could good noise be? There are no studies in the CICU specifically evaluating different types of noise that can be beneficial to our patients, although there is some research out there looking at frequency of noise, such as green or pink noise, and their healing properties. We know that spoken language is good for children and language development. So can it help our patients in the CICU? I would think so. But no one's really looked at that. Music therapy or different types of music is becoming, music therapy in general is becoming more common and more popular, but again, no studies looking at it in the ICU. And then while we have said that the higher decibels are bad for our patients, we haven't looked at a range. Is there a lower range that is bad for them? Is there a range in the middle that's good? And where does that cutoff point be for maximum sound hurting our patients? Just going to mention one study quickly. It's become my favorite study in the last several years, probably because I really like white noise, and this backs up my fandom of white noise. This is a study of 103 stable premature infants in a NICU in China that were randomized to 3 groups. They were the mother's voice group, white noise group, and routine care. The white noise and mother's voice group each received white noise or the mother's noise or no voice for three times a day for 20 minutes. The white noise and mom's voice were controlled at 50 to 55 decibels, which is still higher than the recommended in a hospital or in an ICU, and different variables were measured. Weight gain in the white noise group was significantly higher than in the mother's voice group. The sleep time and sleep efficiency and increase in wake time and after the sleep onset, as well as average awakening time, were also found in the routine care group. So really the only difference they saw was that those who had white noise gained more weight than those in the normal routine group or those who just heard their moms talk for 20 minutes. When looking at heart rate and oxygen saturation, there was no difference post-intervention, but during the white noise or mom's voice, the white noise group had an increase in their oxygen levels during that 20 minutes. So this is one study showing some potential benefit for white noise. Again, not done in the cardiac ICU, but in our premature infants. In summary, I'll close here. I just want to highlight that noise does have consequences, can change hemodynamics, potentially cause stress in our patients, and requires or is associated with an increase in sedation that is given. And then lastly, I think there's more investigation needed looking at different types of noise or sound and their benefits, as well as their consequences in patients in the CICU. Thank you.
Cheryl, thanks so much for that. It's obviously very important. There's so many things that are modifiable that we're learning now are going to give us an opportunity to improve. And many of you on the call are probably familiar with a paper just published by Mike O'Byrne and the group at CHOP that showed a relationship with total opioid use with abnormal Bailey scales at the age of about 2 for cognition, language, and motor skills all across the board. So we certainly can use the reduction of opioid use as you've described, high noise, high opioids. We can start to use that as a marker for QA projects to try to decrease the amount of opioids that kids get for a variety of good reasons. The next speaker, and we miss you here in DC, Cheryl. I hope you're enjoying Colorado.
I do. I miss you all too.
The next speaker is a dear, dear friend of mine I've known for many, many years. Cardiac surgeon who's now doing incredible research and some teaching at Children's Hospital of Philadelphia, Dr. Bill Gaynor. We're going to shift gears a little bit in terms of neuroprotection before the babies are born, and is going to be discussing some important work that I think we just need to unshare your screen, Cheryl, and we will talk about maternal as a neuroprojector. Bill, do you have control of the screen?
Yeah, I'm working on it right now. Just give me a second. I think I'll be okay. Okay. Okay, can you see that all right?
Perfect, thank you.
Okay, so thank you. I'd like to thank Gil and the organizers for allowing me to present this work today. As Gil said, the concept here is we know that there is brain dysmaturity and sometimes brain injury before birth or before surgery. And can we intervene during fetal life to ameliorate some of that brain dysmaturity and perhaps create a more resilient baby at the time of birth to deal with the impact of congenital heart disease and its therapies? Let's see. Okay, I have no conflicts. I am going to discuss an off-label use of vaginal progesterone. Progesterone is an essential hormone for the establishment and maintenance of pregnancy. It has a therapeutic treatment with progesterone is often used in assisted reproductive therapies with IVF and things like that. In addition, sex steroid hormones, including progesterone, are critical to brain development, including the white matter. Progesterone and its metabolites promote the viability and regeneration of neurons, appear to enhance myelination, and the maturation of immature oligodendrocytes. Progesterone has been shown to be neuroprotective in several experimental models of traumatic brain injury. And therapeutic use is also used in mothers who are at high risk of preterm delivery because progesterone can promote uterine quiescence and prevent preterm labor. So this is the Optimum study, which was a very large multi-center study, a double-blind, randomized, placebo-controlled trial of vaginal progesterone from about late second trimester to 34 weeks of gestation in women at high risk of preterm birth. They had three primary outcomes: fetal death or birth before 34 weeks, a composite of death, brain injury, or bronchopulmonary dysplasia, and neurodevelopmental outcomes. In this study, they found that vaginal progesterone was not associated with a reduced risk of preterm birth or their composite outcome. Importantly, they found no evidence of long-term benefit or harm at 2 years. Now, this is very different from our congenital heart disease population. They excluded children with known structural or chromosomal fetal anomaly, particularly structural birth defects. And the study drug was terminated at 34 weeks because they were trying to prevent, extreme prematurity. And we know that there's a lot of brain development that goes on in those last few weeks of the third trimester. And importantly, when you look at the data, while they did not see a overall effect, for most of the outcomes, the direction of the effect was in the benefit of progesterone. And they did find that there was a statistically significant impact on neonatal death with lower death in the progesterone group. And in a subgroup who had brain imaging, there was a lower incidence of brain injury on cerebral ultrasounds. So we hypothesized that there were three potential mechanisms by which maternal therapy with progesterone could improve neurodevelopmental outcomes. It might reduce preterm birth. We've heard about the risk in prematurity. It may enhance brain maturation, particularly the white matter, and there might be a direct neuroprotective effect. So we designed a double-blinded, individually randomized, parallel group trial to explore the superiority of natural progesterone versus placebo on neurodevelopmental outcomes in the congenital heart disease population. The inclusion criteria was a maternal fetal dyad where the baby was likely to need surgery with cardiopulmonary bypass before 44 weeks corrected gestational age. And they needed to be identified before 28 weeks so that we could start the therapy by 28 weeks. And this was a phase 2 trial. This was not a pivotal trial. The primary goal was to provide a range of plausible values for the mean difference in the 18-month Bayley scores and use this data to inform the design of a possible future pivotal trial. The study was not powered to detect treatment effects which we might deem clinically relevant. And this is the study design. We identified and enrolled patients before 28 weeks of gestation. We did a block randomization. This was pre-specified, and we randomized by HLHS, TGA, or other types of congenital heart disease. Prior to the initiation of study drug, there was a baseline echocardiogram, a baseline fetal brain MRI, and then the study drug was initiated. The study drug was vaginal progesterone, an 8% gel, which was equivalent to 90 milligrams, or placebo, which is a vaginal moisturizer, and these were given BID, and this was very similar to the dosing used in the Optimum trial. They got their routine perinatal care and assessment by fetal cardiology with safety checks. They got a second fetal brain MRI at about 34 to 36 weeks. The study drug was terminated at 39 weeks or when the mom went into labor, if that occurred before 39 weeks. They were born, they had surgery, They did get pre and post-operative brain MRIs, and then they returned for a neurodevelopmental evaluation at 18 months. You can see here, this is the consort diagram. We enrolled 102 patients, and we had equal allocation to placebo and progesterone. Because of our great study team, we had tremendous return of almost all survivors. Only 3 surviving children who were still in the study declined to return at 18 months. And these are some of the outcomes. We looked at the impact on the timing of delivery. Induction of labor was more common in the progesterone group. This suggests a biologic effect was occurring in that the onset of labor was delayed. And when categorized into early preterm, and early term compared to full term, almost 60% of the babies, of the mothers using progesterone were born full term, compared to 44% of those using placebo. So again, there appears to be some biologic effect here. When we looked at the overall cohort, again, we looked at the group means, and we did not see a statistically significant impact on outcomes. Although the effects was in the direction of benefit, but it was not statistically significant. And remember, this trial was not powered to identify what we would consider clinically relevant outcomes. It was to get an idea of the effect size so we could decide how to power a pivotal trial. Now, one thing that we had not considered, and I think is very important, is heterogeneity of treatment effect. And this occurs when the response to an intervention differs systematically across individuals. This can be based on biologic characteristics such as diagnosis, genetics, fetal sex, extrinsic factors, adherence to the therapy. All of these may systematically alter the response to a therapy. In many studies, heterogeneity is quantitative. That means that the magnitude, but not the direction of the response, varies within subgroups. That would be that all the subgroups showed a benefit. It was just greater in some subgroups than others. Less often, heterogeneity is qualitative, and this means that the direction of the response varies within subgroups. So that within one subgroup, you may have a benefit, and in another subgroup, you may have no benefit or even the potential for harm. And so with either type of heterogeneity, the overall estimate of the response, what I showed earlier, depends on the proportion of subjects with different baseline characteristics enrolled in the trial. Qualitative heterogeneity can particularly complicate interpretation of an overall effect because the results for the component subgroups may cancel when you pool across all subjects and look at the entire cohort. So this shows some of our subgroup. These were pre-specified subgroups. And as I said, we had a block randomization based on the cardiac defect. And this looks at the Bayley-III motor score. And what you can see is that for HLHS and other, there is a trend towards benefit, particularly in the other category, whereas there is no evidence of a benefit for the TGA patients. Same thing we see here. If we look across fetal sex, there is a benefit to the female subjects who receive progesterone for motor score, not for males. And when we look across the other scores, here's the cognitive score, we see the same pattern. And here, perhaps even greater effect, we see the same pattern for the composite language score. So we wanted to study this and look at this statistically. We used a global F test to identify interactions between the treatment and each subgroup of interest, which were cardiac diagnosis, fetal sex, the presence of genetic anomalies, and a composite definition of an impaired maternal fetal environment. For the motor score, the global S test showed heterogeneity of treatment effects for cardiac diagnosis and fetal sex. As I showed, HLHS was different compared to TGA, and the response of females was different compared to males. For the language score, we had very similar findings. We found a significant F test for cardiac diagnosis and fetal sex, and the scores for the females in the progesterone group were particularly higher than placebo, and the opposite was true for males. So this suggests that there's an interaction between certain patient characteristics and the treatment effect. We also looked at adherence. In the optimum study, the adherence to the study drug, we're asking these moms to take a drug twice a day during the third trimester of their pregnancy. And we looked to see, did adherence affect? If the moms took more of the drug, did we see a greater treatment effect? And you can see here, we looked at both on the top, greater than 80% adherence, and on the bottom, greater than 90%. And you can see, whereas our mean effect was less than 3 points, 2.7 points on the motor score for the overall cohort, if there was greater than 90% adherence, this increased to 4. Again, suggesting a biologic effect, that the more drug you took, the greater the effect was. Interestingly, and we were a little surprised to find this, is that we looked at the impact on mortality by 18 months. So this incorporated the operative mortality and any late deaths that occurred before the neurodevelopmental evaluation. And here you see for the entire cohort that the blue line, the placebo, the mortality was slightly higher, not statistically significant, but higher compared to the red line, which is the treatment group or the progesterone group. Most of the mortality, as we would expect, occurred in the HLHS group. And here you can see that there's a much greater effect on mortality. For the placebo patients, the blue line, the mortality by 18 months was 20% compared to 7% in the treatment group, the group that received progesterone. And we're currently evaluating this out to over 4 years of age and looking at transplant-free survival. So again, the study was underpowered to look at an impact on mortality, but this is an intriguing finding. So to summarize, in this doubly blinded, individually randomized, single center trial, the treatment effect on the entire population of progesterone was in the direction of benefit, but small and not statistically significant. The study demonstrated unexpectedly for us high levels of qualitative heterogeneity and treatment effect among pre-specified subgroups, particularly cardiac diagnosis and fetal sex. And considering these findings, we would recommend continued research into the possible benefits of progesterone for neurodevelopmental outcomes for the HLHS and other diagnoses, not TGA, and that we think that the possible impact of progesterone on mortality should be explored in a larger study. And these findings do suggest that the CHD population may be quite heterogeneous in its response to treatment, and future neuroprotective trials should incorporate the possibility of such heterogeneity into the study design. So, will we ever get to fetal neuroprotection in congenital heart disease? I think yes, but there will not be a silver bullet. And I think this is for the whole field. There's not one thing we're going to do that's suddenly going to make all these kids neurodevelopmentally equivalent to a typically developing child. Treatment strategies will need to be personalized. They may be based on type of congenital heart disease. They may be based on fetal sex. They may be based on some other factor that we haven't identified yet. And incremental improvements are important. Relatively small improvements in mean outcomes significantly reduce the number of severely impaired individuals. So what we think might not be significant for an individual, a 2.5 to 4 point improvement, if we look at the group as a whole, that improvement in mean outcomes, and Gil showed me this is from the lead exposure literature. If you look at the effect of a very small change in IQ of 2 to 3 points, you can see on the left-hand side of this bell-shaped curve, the number of kids that are severely impaired below an IQ of 70. By increasing that merely from about 2.5 points to a mean of 95, the number of, you shift the curve, and that tail, the number of kids who are severely impaired is decreased. So I think we're going to need to get to personalized and individual therapies, which will probably require a cocktail of neuroprotective strategies, some of the things that we've talked about today, and may include fetal neuroprotection. And while I am presenting this data, obviously this takes a huge research team to do this, and I want to thank all the people who helped with this, and particularly the families. So I'll be happy to answer any questions, and thank you very much again for this opportunity.
Bill, thank you. That was just tremendous. It's always great to see new things and have more questions at the end than answers, and that's sort of how we get better. I also want to just say publicly what a pleasure it was working with you, and also the fact that as a cardiac surgeon early on, you were so instrumental at getting a lot of this research done for our patients. Dan, before you jump on, I want to just try one thing really quickly. I'm going to see if this works. This is the first time we're using this on Congenital Heart Academy, but while we still have 300 people on, if you just scan that QR code on your phone, if you're not on your phone, you will be able to participate in this poll to see where people are from. You are the test subjects for for this poll. We'll leave this open for just about 30 or 40 seconds. And these will come up live as we're going. You could see that there's Oceana down here at the bottom. You should see all the options on the phone. Melissa's next to me, and it looks like it does come through. On the Congenital Heart Academy, we've gone back and forth with the best timing for these. And unfortunately, Australia and Japan frequently get the short shift. Krishna Iyer and others from India are on today, and I'm very much appreciative of that. And I'll be leaving this in my showing it up on the YouTube thing. I'm going to go for another 20 seconds or so. Then we have one more question, and then I'm going to introduce our next speaker. We have two more speakers left. We're going to probably go closer to about 11:45, I would think, and we will have time for questions. And again, I want to remind people that may have come in late, all of the Congenital Heart Academy webinars that started in April of 2020, right at the beginning of the pandemic, remain online on the Congenital Heart Academy YouTube channel. You can drop comments there. I will put my email in the chat. If people have ideas for webinars or new talks, that would be great. All right, looks like we're still getting just a few more people on here. It's just amazing. I think it's phenomenal that half of the audience is outside of North America, which we really appreciate. We were struck. CHA has reached 100 people in 107 countries over the 3 years that we've been active. Then one more slide to use here. If you could please comment on what is your profession. Does that show up on your? Yeah, great, Melissa. Nice wide spread. All right, I've got to start working on getting medical students on here. Carly, you have to respond so we have at least one speech language pathologist.
But also there's the implication that neurologists aren't physicians.
It's not an implication. I mean, that's good. I really appreciate people taking the time. We'll probably use this tool moving forward. So you have that QR code now. And if you have time to scan that for I'll give you another 10 seconds. You can answer both questions. And I'm really, really excited to introduce my friend and colleague, Dr. Dan Licht. Dan and Bill Gaynor and I all started working together pretty closely at right around Y2K, if I remember correctly, Bill and I in 1995. And I just want to give one quick shout out to Dr. Susan Nicholson, who's an anesthesiologist at CHOP. Susan was directly responsible for it was just unbelievable. She would get the babies that we were doing research on to the OR around 6 a.m., lining them up, and completely cooperative for all of the studies, including leaving the OR to the MRI scanner and then coming back. And I think a lot of the stuff that Bill and I and Dan and others have published would not have been possible without Susan's participation. So I gave Dan a pretty difficult topic. We've become pretty comfortable with near-infrared spectroscopy, and Dan has certainly been working on other ways to look at the brain oxygen delivery, extraction, et cetera. So I'll turn this over to you, Dan. Thank you.
Okay, thanks a lot, Gil. That's terrific. And thank you for the introduction. So I decided to change the topic a little bit and concentrate really on an instrument that most centers already have, rather than dealing with really exciting developments in optics that are still going to be 10 years from now. So with that, I'll start looking at NIRS. So near infrared is a product of sort of a fortuitous discovery by Britton Chance that there are certain bandwidths of visible light that do pass through tissues. And I hope everybody's hearing me okay.
Perfect, Dan.
Okay, terrific. So there is a differential spectrum for oxy and deoxyhemoglobin. That's one important finding, but also that the differential spectrum is in a zone where water does not absorb any of that light. So in the upper left image is my index finger over a green laser light. And as you can see, all the light is transmitted along the surface of the finger, and that there's very little penetration of that light into my finger. Whereas on the two images on the right is again, my index finger with a red light that shows that light completely passes through the tissue. And in fact, when viewed from above, you can see light coming through the tissue. But absorption isn't the only issue. There's also scattering. Light is both a particle and a wave. And those two properties are not separable, but they're both measurable. So this is a cuvette with a clear liquid and a laser light going through from top to bottom. If we add a little bit of intralipid into the fluid that's in the cuvette, we start getting some scattering of light, and there's a spreading out of the light throughout the cuvette. Now, if we increase that intralipid, at some point you get to the point where the light does not transilluminate the fluid, does not cross all the way through the fluid, but a lot of the light returns to the same surface where the light is being introduced. And this is an important thing that allows us to do NIRS at all, because if you have a tissue where scattering events are greater than 1,000 events to one absorption event, then you can have the source and detector on the same side of the tissue. And you can start doing a statistical analysis of how much of the light that's being introduced into the tissue makes its way back to the detector. Commercial NIRS is great for a lot of things. It's portable, it's cheap. Yeah, I'd say about $30,000, $20,000 to $30,000 per unit. It's non-invasive, and it's very easy to use. Unfortunately, there are a lot of problems. It's not quantitative, and this is because it has this sort of one size fits all or fits no one kind of problem. There are assumptions about the superficial tissues, and you have some big patients, some small patients. There are assumptions about skin color, dark patients and light skin colors. There's skin thickness. The bigger problem is assumptions on the tissue, the intrinsic property of tissue absorbance, not just what's in the vessel, but what's the tissue composed of in itself. There are assumptions on the scattering of light in those tissues as well. And that doesn't take into account the blood flow that we're trying to the blood oxygenation that we're trying to measure. There's also an assumption on the venous fraction. So when you put a light on the forehead of a child, underneath that light, how much of that tissue is actually venous blood and how much of it is arterial blood? And that's probably not a constant, although right now we're limited in how to measure that. And the other thing that's a big problem, probably the major problem with commercial instrumentalization, is that they only give you the cerebral oxygen saturation. They don't allow you to see the total hemoglobin concentration. They don't allow you to see the oxy versus deoxy hemoglobin concentrations. So it's basically a trend monitor. And even as a trend monitor, there are important considerations that ambient light does affect your measurement. And the changes in ambient light will produce changes in your trend monitor. Probe movement is probably the biggest problem. And each time a probe is moved, it resets the baseline. Now, are all probe movements marked and acknowledged? It's hard to say. So this is a sort of a complicated time series where you have time in the x-axis for all three graphs, and you have temperature, and in the middle graph you have cerebral oxygen saturation and a measurement of cerebral blood flow. That is one of these inventions that we've been working with that won't be available for, say, 5 to 10 years. And in the bottom is light intensity as it returns to the detector. So this is a child that's undergoing deep hypothermia, followed by arrest, and the changes that happen in the optical signal. So we have cannulation onto bypass at this time point. We have the changes in nasopharyngeal temperature that are occurring after bypass inhibition. And we have onset of circulatory arrest. So the light intensity change is reflective of the exsanguination that happens at deep hypothermic circulatory arrest and reflects a drop in the chromophores, hemoglobin and oxyhemoglobin. Cerebral blood flow as measured by our instrument drops to 0, which was a very significant finding, as it should. And the continuous NIRS or commercial NIRS reflects both the oxygen saturation, but also a decrease in the chromophore concentrations. And this is important to know. And if you look at the curves that are here, those curves are almost exactly identical. And that's sort of questionable. The peak in the middle here reflects the fact that blood flow was restarted and then a hypothermic arrest was restarted as well. So if we look at the differences between a frequency domain NIRS, which is quantitatively measures the chromophores and the oxygen saturations and gives you both those numbers versus commercial NIRS, we can see that before deep hypothermic circulatory arrest, the trends are quite good and reflect each other. So I believe blue is the commercial NIRS and red is the quantitative spectroscopy. So the trends look pretty good at that point. But when you go into deep hypothermic arrest here at the first black bar, you can see that the quantitative measures change dramatically in different ways than the commercial NIRS. And that's because we're actually measuring the chromophore concentration as well as the oxygen saturation. And when you look at the similarities in these three patients undergoing DHCA, you can see that the value asymptotes at around 50%. And this has been fairly consistent. So at temperatures other than normal temperatures, we can't rely on commercial NIRS. And this is all led, the problems with NIRS have led to discovery of problems like this. Now, this is Bill Gaynor, the prior speaker, and Gil Warnowski, attached to a Covidian NIRS sensor. And you can see that the number that Gil is producing on this instrument is dramatically low and may, in some centers, require intervention. But I can guarantee you he doesn't need an increase in his oxygen carrying capacity. The other problem, this has led to this study too, which compared the NIRS value in different vegetables, and the controls here were human subjects. And I love the conclusion that they reach in this study was that in the wrong context, data are prone to misinform. Although a cursory look at our data might suggest the contrary, we refute any suggestion that a yam or butternut squash is any more qualified a vegetable than a yellow zucchini, or indeed our control subjects. So what are the best uses for this instrument that is now widespread? Well, the best use is a patient that is still, and this will remove a lot of the movement artifact that occurs. So this is intraoperative as long as it's not a deep hypothermia case or in the ICU. And you have to understand the number. It's a relative measure. You have to rule out artifact. Was the probe moved? Was it replaced? Did the EEG text putting on the EEG move the NIRS probe? Was it moved just from the child's movement? If the number goes up, what does that mean? Well, it can mean either arterialization of signal, in other words, the brain is dying, or pentobarb was started, or there's a decrease in temperature, or it could also mean improved oxygen delivery. If the number goes down, does it mean that there's a decreased oxygen delivery? For example, decreased oxygen content, or a decrease in chromophores? If there's an increased oxygen consumption, this can happen without increased delivery, and the number goes down. So are there better uses of this technology that we can do? Well, two things that come to mind are fraction of oxygen extraction and autoregulation. I'm going to start with cerebral oxygen extraction fraction. And this number should be the AVO difference. How much oxygen is offloaded into a tissue between the arterial and venous blood flow, where the oxygen saturation is the pulse ox, and the SVO2 should be from the jugular bulb or deeper in the cerebrovenous system. And you can do this calculation by simply a subtraction of SaO2 minus SVO2 and divide that by SaO2 to get the fraction. If we assume that the NIRS number is approximately 75% venous and 25% arterial, we can then make an assumption on oxygen extraction fraction by looking at a 25% of the NIRS value from the pulse ox divided by the pulse ox number, and you can get oxygen extraction fraction. This is an incredibly important number, the oxygen extraction number, because if the oxygen extraction fraction goes up, it can only be a deficit state. The brain doesn't care what the saturation of the blood is. It only cares about how much oxygen it can extract from the vessel. So if your oxygen saturations are 85%, and the amount of oxygen capacity in that blood, the brain doesn't care what the saturation is. When you start seeing oxygen extraction going up, though, the brain is running out of oxygen it can extract from the circulatory system. Autoregulation is something that we all think about, and that's the ability of the brain's vessels to dilate or contract depending on the blood flow to the brain. So in this diagram, we have blood pressure, systemic blood pressure on the x-axis, and cerebral blood flow on the y-axis. And at very low systemic blood pressure values, you start getting a correlation or a dependence on the blood pressure. In the mid zones, this is a blood pressure that that is continuously regulated, so is completely uncorrelated from blood pressure, and this is to maintain a very stable cerebral perfusion pressure. At higher pressures, it then becomes correlated again, and blood flow to the brain is again passive with blood pressure. When blood flow to the brain is passive with blood pressure, this is a highly abnormal situation, and there is risk for injury. It doesn't mean there is injury, there's only risk. At low end of the systemic blood pressure, there is risk for ischemia, and at high end, there is risk for hemorrhage. And we can define these areas on the curve as the lower limit of autoregulation, the upper limit of autoregulation, and in the middle between the lower limit and the upper limit as the optimal blood pressure for cerebral perfusion. So how do we get these numbers? Well, all that needs to be done is a synchronized, time-synchronized measure of arterial blood pressure with the NIRS number. You run a correlation, a Pearson correlation between those two values, and you can retrieve a number that says the degree of correlation between systemic blood pressure and cerebral blood flow. And with continuous measures across a wide range of arterial blood pressures here on the x-axis, you can look at high correlation. The correlation coefficient is here on the y-axis, areas of high correlation, and as the blood pressure continues to increase, you discover that there is an inflection point or a lower limit of autoregulation, and a nadir, which is optimal blood pressure, and as the inflection occurs on the other end of the blood pressure spectrum, you can measure the upper limit of autoregulation. Now, these numbers are not readily available to the clinician now, but that day will soon come where our vital sign capture instruments, like sickbay, like bedmaster, like many others, will include this continuous measure of correlation between blood pressure and blood flow. And this is more in our immediate future. So in the end, the number that is currently streaming off these devices is not all that useful clinically, but integration with other measures will make these numbers much more clinically relevant. And with that, I'll turn it over to the next speaker. Thank you very much.
Dan, thanks as always. A great description of NIRS, and just like Bill's talk, when we have more questions than answers, we keep getting better. Those incremental changes that we make, I think it's terrific. I was a skeptic with NIRS, especially when I realized mine was 27. But I certainly use it now as a trend marker in the unit. I find it helpful as another tool to integrate with everything else. So that was terrific. And our last speaker, and I appreciate all the people we still have over 250 people online, which is wonderful. The next speaker is someone I've had the privilege of meeting and working with for the last 3 years or so. Dr. Yves Dudekem's the chief of cardiac surgery here. 4 now? Time goes by so fast. Yves is our chief of cardiac surgery, and just a pleasure to work with, a technically superior surgeon. And I asked him to wrap things up with his own thoughts, his own perspective over his career and where we are with neurodevelopmental care. Thanks, Yves.
Thank you very much. So I'll give you a certain perspective. I have to disclose my complete lack of knowledge in neurology. On a short story is that I always pass all my exam at first pass, except for neurology, where I almost failed the exam twice during my medical studies. So my words will be coming from my experience. the things that I have heard and believe it does not come from an extensive knowledge of the literature on the topic. So I'll distinguish when I call about neuro stuff, about the small things and the big things. And so the big things is the disaster. Somebody come to me and they start saying things like, oh, this kid will be blind, he will never see, she will likely be bound to a wheelchair. And then automatically in my mind, I think, okay, that's it. Somebody is trying to assassinate my kid or the kid I just operate. And I'm sorry for the language, but and when I look at things, I am disappointed somehow by the information I can gather to build up an individual prognostic for that patient. I'm old enough that I saw the development of the MRI in the 90s. And when I look at long-term consequence of the brain MRI lesions that we see, yes, we know that it's bad and there's a lot of bad things, but it's difficult to say that what that patient is going to have that long-term follow-up. And all we can get is that usually, and we had that discussion with Sarah, and I'm sorry for my interpretation of this discussion, but basically you look at the lesion of the brain and you look at what the function of that section of the brain is, and then you make a guess on how bad it's going to be on the impact on that function. It does not take care into consideration the brain plasticity. And we know anecdotally that we have patients where prognostic was made, the parents do not follow on the discussion, and you see a remarkable sometimes recovery in patients that looked initially quite disastrous, and have quite a few examples. And so it's not my area of expertise, but it has been seen that a lot can be achieved in these patients with initial brain injury. They seem like, if you look at pediatric traumatic brain injury, the thing that is the most influential in the outcome is not so much the extent of the lesion, but the education, the support that these patients will have by their family. And I couldn't but notice that one paper, okay, it's only one paper, where they say that prognostic formulation developed by clinicians and payers in relation to persons with traumatic brain injury of the severities included in the study sample, particularly in the early post-op injury period, need to incorporate the present study findings and to avoid, I like the way they phrase it, to avoid the tendency towards prognostic and therapeutic nihilism that has become too common in this area of medicine in recent decades. And I'm sorry to say, but when you talk about brain injury, you as a surgeon, you have to know who you are talking to, because people have different views, and it may be useful at times to have perspective from different people. And so you have to see, what are your goals? What do you want to achieve? What do I want to achieve as a cardiac surgeon? Is fairly simple. Cardiac surgery, for me, is a discipline that aims to have functional individual, people who can move, progress, and my criteria is having a patient who can ultimately pay tax. If it pay tax, it may not be the most educated person in the crowd, but it means that you have your role in your society, because the society is not helping you. You provide something to the society. And you may not be a lawyer, a banker, or having a high job in a business or insurance company, but these are not the type of job I have a lot of respect for anyway. A brain injury is worse than death for a surgeon. We, as surgeons, have a trial. We are sued more often for brain injury than for death. It's easier for us to have a dead patient, but in America, you have this famous US News report scoring, and that is different. So a death is costing you maybe a lot more than brain. Probably we keep alive in North America patients that I have seen where we would have abandoned treatment in other parts of the world. Fortunately for me, in the Children's National Hospital, we are humans. If we think that the lesion is too severe, we are stopping treatment in this patient. So because I was frustrated by the lack of prognostication, I've asked the young student, the young doctor here, Dr. Justus Reitz, to review the whole experience of the Children's National and gather long-term outcomes. So I phoned him over the weekend. He was doing this hike of 50 Ks in the summits of Austria, and I asked him to send him a little picture of himself in the site when he had answered my phone. So we had operated and reviewed the files of 3,500 patients operated between 2007 and this year. A third of the, almost a third, 29% of these patients had some form of brain imaging by CT or MRI, which means that we had some suspicion that something had happened during or after the operation. 70% of those imaging had some injuries or anomalies, with 16% identified to be severe, and impact the long-term outcome. So we had a very gross estimate of the outcomes, the pediatric cerebral performance category scale, where you can be normal, have mild cognitive impairment, so you have the same grade that you're supposed to be with your age, but your marks and all that's good. You may have some assistance in daily life. Imagine you at a lower grade at school, or you have assistance with multiple daily activity and 5 being coma and 6 death. So we had a no late outcome on 147, so on the total of 888 patients, about 50% are either normal or have just mild impairment. It's clearly a big issue because 20% of those with a CT or brain MRI, so it was 30% who had imaging of the whole lot, which means like it's close to 10%. Ultimately, these lead to death. 10% of the total, with a small proportion being coma, and still about 29%, so close to 15%, 29, so 10% of the total, need some assistance in daily life. So it is an important problem. And if I try to distinguish what is really bad, well, my own assessment of neurological damage is like, I used to say that I look at the imaging from 2 meters away, and if I can see something, usually it's a bad news. The other thing is that if you have a bilateral hypoxic injury and continuous seizing, I have been said by people who have looked, and in George Washington University, there's a team who has done a lot of studies on patients who had brain injury and evaluating them at adolescence and early adulthood, that seems to be a bad factor. On a personal level, despite all what Daniel said about the knees, and I know it's not a perfect tool, but I found out from experience on several patients, unfortunately, that if you have a lactate around or over 10 and a knee is less than 30, I've seen dramatic neuro outcomes, even in patients that seemingly seems relatively stable with not too much inotropic support. But if you, in that situation, you don't have time, 10, 20 minutes, and you should go back on bypass. And that's a patient where we were waiting to set up the ECMO and stayed without bypass, while the bypass was just next to me in the OR, and having these 40 minutes with a NIRS below 30 was fatal in that patient. There's other surgical stuff that you can work on to make things better. I'm always scared to have an RV2PA conduit because you can have gas embolism. You have to realize that the left ventricle, as it relaxes, does generate quite an important negative pressure. And you can have these tiny bubbles going slowly from the right open side to the left side and being ejected into likely the brain most of the time. And I've seen patients having severe cerebral injury after a stupid RV2PA conduit in an adolescent. And so if you see the smallest shunting, you should clamp the aorta and do it on the circulatory arrest. Cardioplegic arrest. Most of my experience comes from being an expert witness in legal cases. One thing that I've seen, for example, doing a single cannulation versus instead of cannulating both the SVC and the IVC for an RV2PA conduit. Yes, you can do it, but then that patient had a knockoff of the a cardiopulmonary bypass. The cardiopulmonary bypass stopped because there was too much air that was sucked. Why do you want to put yourself in an uncomfortable position and take risk? That patient did not go well. Gas embolization. Again, I had to review some cases. You have to be ready to know what you're going to do if you have a massive gas embolization. We reported 2 cases of Glenn, so 3-4 months of age patients who went straight to the hyperbaric chamber after surgery. And what I do in this case personally, I cool rapidly, I put the head down, I do a retrograde perfusion of the SVC and opening of the aorta to de-air any air that can be still trapped into the carotid arteries or the more distal vessel. I do a swift operation. Sometimes I modify my operation to have a faster operation. And I rapid transfer to oxygenation hyperoxybaric chamber. No waste of time, no imaging. You're going to waste 2 hours if you try to have a brain CT or brain MRI. And we had one patient who ceased just after an RV2PA contact early after arrived here. The patient was transferred to the University of Maryland directly. You must have a pre-established plan in your unit for air embolism because these cases will happen. You should not have that discussion at the time of the event because you're going to waste time and you have just a margin of a few hours, and you have to know in your area which unit are going to be ready to take your patients for hyperbaric chamber because not all of them are doing that. Regional perfusion versus circulatory arrest. We have a good proof that provided that your circulatory arrest rests within the limit of half an hour, you don't claim much risk. We should have more investigation of the circle of Willis. We do brain MRI in all our patients, but I go to surgery and I do a regional subarachnoid perfusion. I don't know if that carotid artery that I'm cannulating is perfusing the entire brain. And you have to be cautious on the bypass in the fontan circulation because it is known that a lot of these patients have high cardiac output status, and these patients will need higher flow than the usual flow on bypass. The small stuff, I have been saying that I'm limited to the chest and whatever is above or below is not of interest to me, but I have to recognize that you have an impact of neurodevelopmental outcome only a small proportion, if you listen to the seminal paper by Bill Gaynor, is related to surgery, ECMO, and cardiac arrest. The question I still have is there's a wide variation. I don't know what happened to these estimates of neurodevelopmental outcomes if we remove from this list the patients with the big damages. And I still don't know if you have a VSD and an ASD, whether that small defect has an impact on the long term for you. But we have to take care about this neurodevelopmental outcome because when I did my work on the fontan population, this is the primary concern of the family. Interestingly, the kids, the adolescents, they're most worried about their physical capacity, and their psychological well-being is the primary concern beyond death for the parents. And so if you look at these fontan patients, they do have a decrease of neurocognitive function. It's related to more inpatient days, so the people who have bad time at the first time of surgeries, younger age at surgery, and longer time since fontan procedure. They all have some small abnormality in the brain injury, but it's more the white matter changes that seems to be determining the neurocognitive functioning in these patients. TGA, I'm a non-believer on the fact that we should do the switch early, but the evidence is there, and so we've adopted a strategy to operate them within 48 hours. What can we do? Well, Melissa has beautifully explained that, we need to do psychological support and look at the family early in life, because the most important factors affecting the presence of anxiety or depression in these adolescents is actually the mother, a child, mainly mother, a child, but the parental relationship with the adolescent and the PTSD that they develop early in life is the main factor playing a role in the development of anxiety and depression at a later age. Social support and education. We haven't talked much about it, but there's a clear association between the social determinants of health and pediatric and outcomes, neuro outcomes after injury. And we've published now in a series of work that the population who's got worse, the lower 2 quintile of socioeconomic background here in a dark orange have 50% higher mortality after surgery than the people of the 2 higher quintile. And that is driven by a likely prematurity, small birth weight, and associated with genetic conditions. But we haven't done anything. We know that education, support of the children, will have the largest impact on the neuro outcome, but we haven't invested in the support and the indication in this patient after surgery. And then we should understand better what we're doing. I just want to mention what Sarah said. We had 26% a few years ago of post-op seizure. It has evolved to 11%. And I cannot but notice that at the same time, during the same time period, we had a vast decrease in the mortality. We're very proud to have a full year, the last financial years, with 0% mortality. So I think that there's a lot of work we can do around the surgery itself, but surgery must have an impact. Daniel has explained to you the development of cerebral autoregulation. We have now demonstrated that the cerebral autoregulation preservation in the first few days after surgery impact the neurologic outcomes. Even in surgery, and we're doing prospectively studies of cerebral autoregulation within surgery, you can have patients develop subdural hematoma, not only because they have a lower blood pressure, but there's a slightly higher blood pressure in a newborn in the 80s. And you see the continuous reading that we can have instantaneously here in this arrow can give you a risk of bleeding. So we should adapt the cardiopulmonary bypass that we're doing in a way that is better for the brain. And we have now a door open because we have an endpoint. We have these continuous EEG monitoring, which give us an immediate surrogate endpoint for how well we're doing bypass. And I just want to flag that we're organizing a heart valve repair symposium in October with lots of videos, and you're all welcome to join us at that day.
Yves, thank you for a very thought-provoking presentation. And I think everybody who's been on the video today, on the webinar today, gets an idea of what our discussions are like on a frequent basis in the ICU. And it certainly reflects our team's interest in the neurodevelopment of children. I think someone was asking in the Q&A about how important it is. Do we have enough time to do it? We can't afford not to be thinking about the brain, because as Yves showed, that is the fundamental thing. Physical well-being, am I going to die? And then after that, it's psychological and physical well-being. So preserve myocytes, preserve neurons, and preserve families. I'm waiting. There was a question that came up. Hold on. I'll find out exactly what the email should. I'm going to type Grace's email in. We have certificates of attendance if people are interested. We don't have CMEs. Going through CME processes and CEU processes with disclosures and all sorts of objectives and whatnot just exceeds our bandwidth right about now. Let me just I will get Grace's email into the text right now. Do you have it right there? Oh, Melissa's typing that in right now. And if you have any questions, we have a chat box on our YouTube channel. Please share this with people at your center. They can watch at their convenience. You can watch any of the individual lectures over again. Melissa says you could see her slides again, that various publications. The last thing I'll say is, now that American football, college football has started, baseball, United States, the World Cup stuff is getting ready to sort of kick back off.
Yeah.
This is a team sport. The days of thinking of I'm just the cardiologist, or I'm just the bedside nurse, or I'm the neurologist coming in for a consultation. You want to find people who are experts and work with them, and take their suggestions and their advice. And you will see the benefits of that. We have such great karma in our group, and we're glad that we're moving things forward. I want to thank all of the speakers for joining us today. And with that, I will close. Wait, there's one more Q&A, I think, here. Oh, you're very welcome. So did you type in the
Yep.
in where in the chat?
Yep.
Okay, so in the chat is the email for Grace and Grace Van Leeuwen, who's one of the founders of this academy with myself and Sasha Agadi, and you can get a hold of a certificate of attendance from her. Thank you all very much, and I look forward to being in touch with you after CNOC. The Cardiac Neurodevelopmental Outcome Collaborative starts on Wednesday. We will put together the best of, and we will have a follow-up webinar probably in October. Carly, you can count on being back on. Thanks very much.
Bye, Carly.
All right.
Thanks, everyone.
That was so fun. I learned so much from all of you guys.